see how stroke is managed. It has been managed for many years now. So the first and primary thing is medical support. First is look at the blood pressure, see if it is very high. So if the pressures are within 185 and 110, try to keep it high. Don't lower it immediately, because if it is too high and not manageable, that is a different scenario. But if it is like no hypertension with high BP, because the advantage of keeping the BP little high is that the patient will have a good coronary circulation because of the basic arterial pressure inside. So it will give us more time to treat. But if it is too high, we have to try to lower down with beta blocker and mannitol. Mannitol nowadays is another controversial. Some clinicians use it, some don't want to use, no way to use it. But beta blockers most people use. Then antiplatelet medications, usually after intervention we start, immediately we don't start. And GP2B3A inhibitors also, primarily is a medical treatment which I usually start when I see patients with post-myocardial ischemia or during interventional ischemia, because they are primarily platelet clots which you see after post-MI intervention or any other intervention you are doing, and you will end up with acute ischemic stroke during the procedure, like you are doing a flow diverter or a complex aneurysm coiling, and you see immediately one branch occurred during the routine runs. Then eptifibatide or the common drug integrin or axicimab, these drugs you can use intraprocedural. But acutely, I don't prefer to use these drugs, and they're not recommended unless it is a during intervention operation. Then you have neuroprotection, hypothermia. Hypothermia really works well for the patient. If the patient is kept in a lower temperature, it really works, because hypothermia itself is a neuroprotective mechanism for the brain. And I don't know if you have seen how hypothermia of the temperature is controlled very nicely. In Europe, most centers have it. Very few centers in India I have seen actually having hypothermia. And then drugs, neuroprotective drugs like citicoline, and there are many other drugs which are experimental, are used for stroke. So these are the basic medical treatment. Medical treatment is when you see that the patient is stroke and want to prevent further complication in marriage. These are the medical ones. But acute setting, major problems, what we do is thrombolysis. Thrombolysis is the key word, and we use something called the TPA. TPA is tissue plasminogen activator. Most of you in your MBBS must have heard about drugs like urokinase, streptokinase. Those used to be the older generation thrombolytic agents. But in today's era, we don't use those kind of drugs at all. What we use is TPA. The common drug you should all know is known as alteplase. And the brand name is Actilize. Okay? So very commonly used tissue plasminogen activators. This all, at least this basic drug should know. Like saying, mechanical clot retrieval, angioplasty are another intervention mechanism which we have two sides. Anticoagulant is very, very controversial. I don't start anticoagulant in most ischemic stroke unless I see particularly clinical syndrome where I see Carotid artery with floating clots. But I can see on the color Doppler the clot is floating, or I see on the angio that the clot is hanging. Anytime it can go. So just to prevent it, there are many trials which are not so positive for anticoagulant, but we as a team of vascular interventions and vascular surgeons, other physicians, we usually see a patient as an individual patient and to look at the entire thing and then decide whether anticoagulant like warfarin or something called the NOACs, that is a newer anticoagulant needs to be started. So thrombolysis or TPA, what are the benefits? So there is a very complex system. I know all of you are aware with the clotting, cascade, the plasminogen, the fibrin clots, how it is formed, how the plasmin acts in form, having the fibrin degradation product. So the tissue plasminogen activator is actually this plasminogen, the plasminogen which is in the tissue, that gets activated, tissue plasminogen activator. And this is really, really helpful in opening the blood vessels. So it's beneficial, and then TPA, the pre-synaptic vascular, all these things can help, and also activate the microglia also helps in the stroke treatment. So it's not just the vascularity or a particular issue. This is a complex thing. As you all know, brain vascularity is not just a blood vessel like any other organ. It is a neurovascular, and all the vessels have their own nerve supply. There is if you go into the microscopic appearance of these blood vessels, all these vessels have a neural supply around the blood vessels. So, the routine drugs that we use for, peripheral circulation does not necessarily work for the intravenous circulation because the mechanism is different. So, detrimental effects also very appropriate, and these are all like theoretical points. I'm not going to detail, but this is just a basic slide for your idea that what happens in the TPA. So, TPA, what is the benefit? We all know. Okay, the stroke will go. The patient will recover. That is the benefit. The worst complication of TPA in not carefully chosen patient is this. That is the large neurologic stroke. And then consequent problems like patient medical clinicectomy and the complications of clinicectomy, pressure effects and all this other stuff. So you have to choose the patients carefully. Again, the app is for resting. We have very beautiful apps now. So whenever we give you TPA to a patient within a particular time window period, we have apps to, just checklist apps where you can feed the data, see the thing, what is the information required, ask the patient and the family, and then choose the data, and then decide on whether TPA is required, not required, and then what dose has to be given. There is, like a bolus and then so see, we all are now postgraduates or fellows, post-MD, post-DMD fellows doing BA or intervention fellowships. So we should be talking like laymen. We should talk in terms of trials. You all are now not in MBBS or not in MD, for the BM candidate. You all should talk pure science. Pure science means trials, the papers, the research. So this may sound boring, but if you don't know this, you can never improve your practice. You cannot you can never make informed decisions. So you should all start spending time with this trial data, with registry data, with various publications on important topics. Because if you don't know, you will not be able to speak to international trained physicians and surgeons or radiologists, because everyone there, we have separate sessions for research and this trial evaluation. Every Friday we have this, research meets and research things happening there, which unfortunately is not happening in India at this moment. In many centers. Many centers I know it is happening and people are actively participating in doing this activities. But in many centers it is not happening, which is really unfortunate, because you should be really, if you're doing good work, that means good work comes only from good and sound academic knowledge that will come from these trials. So I will not take you to the many hundreds of trials done in stroke. Very basic, standard, renowned trials I want you to at least know and hear these words at least, so that in the future you know something, and some trials existed for stroke like this. So one of the very important trials, the NINDS trial, which is the National Institute of Neurological Disorder and Stroke trial. So they actually initially were very much pro TPA, and they say the patients who TPA within 3 hours of onset had much more better or functional independence. Functional independence means they will not have much of dependency on the family or themselves. That means they have a very good recovery at 3 months' time if the TPA is started within 3 hours. So these small research trials, they actually form the basis of the work that we do today. How we do TPA, how we do imaging. So these trials really formed a very important basis of the current knowledge that we have in stroke, and that form the basis of the future treatments also. So this is another score, ranking score outcome you see the patient with placebo and TPA. I don't know whether you are able to interpret the ranking scales, but this all you should learn. Should go spend some time in learning the research methodologies, and so that you will be able to appreciate the trials and these research publications better. Then there is another trial group, that is ECASS, European Cooperative Active Stroke Study. Very famous trial again. They had first trial, second trial, third trial. they came up with increased window period for the IV LTP, that is TPA. They pushed the limit from 3 hours up to the 4.5 hours. So they said initially that we are seeing very good response with TPA patients who are getting treatment within 4.5 hours. So they published this important data in English Journal of Indian Journal of Medicine in 2008. It's a very, very important trials. Another SIT study published in Lancet, then again quoted in Stroke 2008, 3 to 4.5 hours entry place, showing very good results. So these basic trials, as you can see, gave us the confidence and the research so that we can use this drug further. And so TPA, again, American Heart Association also endorsed this and did meta-analysis and advisory. They released in 2009 that we can use this TPA between 3 to 4.5 hours with good outcome. European Stroke Organization also in 2009 gave another recommendation that TPA can use within 4.5 hours. So you see, this whole scientific data is there to suggest that we can start IV TPA. We're talking about IV TPA here. That means intravenously whenever you diagnose stroke, within 4.5 hours of onset of stroke. That means the patient says, I was well 2 hours back, suddenly I was watching a movie, I got a stroke. That means 2 hours before, you should consider the window period. Or a patient comes at morning 6 o'clock and says that the relative brings the patient and says that, the relative was okay, he was watching TV, everything okay, he went to the bed at 10 o'clock at night. Suddenly, when he woke up at 6 o'clock, we found that he's not able to move one limb. He's trying to call us, but one limb is only moving and the other limb is not moving. That concept will be the last thing normal. That is when we saw him normal at night, because we don't know when he actually got the stroke at sleep. Okay. So this is the time window. Another trial, Proactile, they published in 1999 itself, and they showed, but people were not, having that much trust with this trial because they, 99, that imaging was also not so good, and the clinical benefit they were not able to document in a better way. So they said the 6 hours also we tried thrombolysis in the Recanalised stroke, the subcutaneous, they're doing good. So now, after ECASS III study, there is almost a general consensus that less than 3 hours, which you can extend up to 4.5 hours. So remember these numbers. Less than 3 hours, which can be extended up to 4.5 hours, intravenous TPA, that is tissue plasminogen activator in the form of alteplase, can be given to the patient when you document that patient has having an ischemic stroke and patient does not have a hemorrhagic stroke, and all the other criteria to giving thrombolysis. So this number you should remember. Then comes the other treatment group where we give TPA, but we take the patient to the cath lab and then give TPA. That means we take the patient to the angio suite, to do a DSA, we find the occlusion where the clot is, and we relate that to the imaging finding, the same clot seen, exactly the same MCA or AC or wherever we're seeing, and then we're trying to look at the timing and the response there, how the clot looks like, what is the angio looks like, and then we go locally into that particular area with the help of small tubes called an active catheter, and we give localized tissue plasminogen activators. So that is from 3 to 6 hours. So, but that particular time is very non-specific time, 3 to 6 hours. We try to give TPA there and see if it opens up. We try to give as much dose as possible. Like we start with 1 or 2 mg, 5 mg, 6 mg. Maximum TPA you can give as a 25 mg, the safe limit. But I personally feel 20 TPA is something which we should limit to at initial one group in acute stroke, because hemorrhagic complications increase drastically with increased dose of TPA. So we give locally TPA and see after some time, 5 minutes, 6 minutes, 10 minutes, you just do some small angio runs and see whether the vessel is opening. If it's opening, don't do anything, bring the patient back, and you can continue some TPA infusion or the cerebral protectives and other drugs you can add to. But beyond a certain time, the TPA is not showing any response. You go to other intra-arterial treatments, like thrombectomy, which we'll discuss in next few slides. So now, strictly speaking, this time limitations are mainly for the anterior circulation. This rule is not for the posterior circulation. Posterior circulation means basilar artery and its branches. Posterior circulation, we have seen in the real life also, that even if you do the interventions like 12 hours, 15 hours, 24 hours, the prognosis is very good because there is a very good collateral circulation there. So posterior circulation, ischemia, you can extend the treatment window also. So depending on the patient and the patient's image. So TPA, there are certain contraindications. If you see blood, you don't do older patients, 80 and above, never give TPA. They usually do very badly. Patients with anticoagulants or high INR, like patients with liver disease with INR of 2, 3, don't try to attempt TPA. Patients on other anticoagulants, regardless of INR, like patients already on warfarin, INR, patients INR is 3, 4, with the anticoagulant, never give that TPA. Those with baseline NIH score of 25 or higher, try to avoid TPA. Those with both history of stroke and diabetes, this is something, I would not agree with completely because most patients with stroke have diabetes, or at least most of them have, not all. So, diabetes is such common in the country, so we cannot discriminate on the basis of diabetes and not. So, coming to the newer trials, which changed the management to a different level of stroke. One trial that we should remember is the MR Clean or the Mr. Clean trial. It came out in 2015. So, in a very prominent journal, the New England Journal of Medicine, they published this randomized control trial, which say that intra-arterial treatment administered in 6 hours after stroke onset is effective and safe. So that opened the complete window and the spectrum of other management, like the mechanical treatment availability, which was already available, but we needed a substantial proof and then trial data to support that. So MR Clean did that at the correct time. MR Clean gave us a very clear-cut, evidence that, and this trial is actually funded by the Dutch Heart Foundation, among the very properly done trial. So this trial actually, after this, our stroke volumes in many hospitals that we learned actually increased, and this actually helped the patient getting better care. Another trial is the Dawn trial. Dawn trial also came in New England Journal of Medicine, another very good journal, and it was published in 2008 as very recently. So this changed the paradigm of the stroke treatment again in a different way. As they said, a 6 to 24 hours after stroke, you can mismatch the deficit and infarct, and you can do the treatment and with a good outcome when you look at the 90-day. So this particular trial, I would like to again take you back to the imaging tree that I told you, that is the collateral imaging. So if you look at the collaterals, as I said, if the patient has a good collaterals, you can increase the window period. Rather than the time, just only looking at the time, if you look at the blood vessels and look at the collateral supplying the brain, you can very well predict that the patients who are actually doing well from 6 to 24 hours and up to 28 hours also, those are the patients actually having good collaterals. It is not happening just by chance. This is happening because you are getting better time to, more time to intervene. The reason is the collaterals. So go to the subgroup and analyze the subgroup. You will realize that these are all patients who are did well at, a very advanced time window of stroke intervention. You are actually the patients with very good collaterals. So coming to the interventional management, I discuss IV treatment. IV is you give IV TPA. Another treatment you go is the intra-arterial TPA with the microcatheter. They are all like basic simple treatment. You go with the microcatheter into the clot, you give some clot busters, remove the clot and open the vessel. But if all these measures fail and you have a good window period, you actually see that the penumbra is there, you can save a lot of brain. There is a lot of mismatch. You can save, to attempt doing something called a mechanical clot retrieval. So mechanical clot retrieval can be attempted within 3 to 6 hours of the TPA time. Actually, if the TPA is failing, or beyond 6 hours, you should try to attempt mechanical thrombectomy only. Try to avoid TPA in that particular time because the chance of bleeding is very high. So use mechanical clot retrieval for beyond 6 hours. So these are not hard and fast rules. Every patient is different, every patient's imaging is different, every patient's collateral is different, age is different, imaging, clinical features are different. So you have to always individualize on the patient, depending on the patient's end. So you cannot say that, this patient came at 6 hours, you should do like this. So depending on the imaging and other parameters also, you should decide. So basically and broadly, if you see mechanical clot retrievals, there are two types of mechanical clot retrieval. One is a stent retriever. Basically, you deploy a stent into the clot, capture the clot, and pull it out. That is a stent retrieval of the clot. Another thing is aspiration device. You take a catheter of a bigger size into the clot and you suck it out. It's a suction device. That is called aspiration device. So stent retrievers are like Solitaire, Trevo, these are the common stent retrievers that we use. Aspiration device has really taken the entire stroke treatment to a different level because now more and more we are using this kind of aspiration devices. Most common of them is the Penumbra system. So there are many systems, but I thought, I'll just bring to the common that routinely we use, you should know at least. Like if you remember Solitaire as a stent retriever, it is okay. If you remember this Penumbra aspiration device, it is okay. At least you should know that these two things are used commonly for mechanical clot retrieval. The Solitaire or Trevo or Revive, how they work, you basically cross a wire through the clot, a micro wire. You put a microcatheter over the wire and cross the clot. Then you put a stent retriever like this inside the microcatheter. Then you slowly remove the microcatheter, leaving the stent in place. So as you can see here, the stent is actually captured by the stent retriever. So it will be deployed in the clot. And you see here, we have something called as a balloon guiding catheter. So what we do, just before we pull out this catheter out of the brain, we inflate this balloon catheter so that no blood flow goes in and there is no accidental detachment of this clot which we are removing to the deeper circulation. We inflate the balloon, immediately we retrieve so the clot comes like this. This is one of our cases. You can see how the clot nicely is captured within the stent retriever and it is pulled out of the brain. This is how the basic stent retriever looks like. This is the stent retriever which gets collapsed inside the microcatheter. Once you remove the microcatheter, it opens up. So this is the pushing wire, this is the detachment joint. And nowadays we have a detachable retrievers also. After 2-3 passes, when you see there is the clot comes out, but there is a intracrinial stenosis that caused the clot, you can deploy the same stent, thus saving the cost of another stent. These all neuro devices are pretty expensive and many lakhs. So this saves a lot of cost when you can deploy the stent retrieve and come out into the patient. Then we have the aspiration system. When we started our career, we were using this Penumbra 5-max, 3-max system. Now we have different ACE catheters. Like in June 2013, we have the ACE-60 reperfusion catheter. May 2015, the ACE-64 was launched. In June 2016, ACE-68 reperfusion. So there is continuous innovation happening in this perfusion technology also. And this is the canister with the suction device. This is like a basic suction where this tubings, you see this tubings, we connect to this aspiration catheters, which are very soft and supple and are meant for the intracranial circulation. We have no similar devices for peripheral circulation also, but these are the very commonly used neuro reperfusion catheters. So we very commonly use 5-max and 3-max system, and we use sometimes triaxial system to go into the brain and aspirate the clot. This is the canister where the clot and the blood gets sucked out. So I will share few cases from our hospital, Apollo Hospital, Chennai. So you will get a basic practical idea of what happens and what we do. So you see, And given some time here, time signatures are very, very important when we talk on acute stroke and acute stroke treatment. You see here, you see occlusion of lentiform nucleus here, as I was discussing. You see a hyperdense MCA here, imaging done in our hospital, very nicely showing the imaging features. Then we, at the window period was good, it's an IV, TPA, and ER. You see this is the actualized, how it comes, 50 mg and 25 mg, it comes like that. So at 4 hours, 16:15 at 4 o'clock, we don't see any improvement. Whereas the patient for this initial angiogram, right MCA, you see there is complete occlusion. We tried retrieving this clot with the stent retriever. 2 passes we made, but there was no success. So immediately, this is how our stroke setup is with the Penumbra setup. We see this patient with a thrombectomy catheter system in the brain. This is the aspiration tubing catheter, which is attached to the canister and the mechanisms in this canister system with the suction devices. This is how the setup looks like. And once we put this near the clot starts slowly sucking, the catheter starts sucking the clot slowly in a controlled way inside the catheter, so that the other brain vessel does not get injured because of sudden suction. It's the controlled suction, which this technology they have developed in a very nice way for a controlled suction of the clot. So you wait for some time and then see how it is happening. We've seen the clot coming out very nicely. So you can see in this case how a clot came out very nice and big clot, and you can see immediately there is complete recanalisation of the right middle cerebral pathway, post thromboaspiration. So on day 2, we re-image the patient with time of flight imaging. You see there is continued recanalization of the vessels, showing very good secondary follow-up imaging. Another case, limited MRI, DWI, flare, ADC, you see there is an infarct there. Here we are not seeing much of a change. Mild edema or mild hyperintensity, you can see IC. If you really see the flare, you will beautifully see this protein thrombus in the IC. I hope you are all able to appreciate this when you are doing it. There is a thrombus in the chemist portion of the right carotid artery. We can, for the patient for angiogram, you see there is complete cutoff for the right side. You cannot see any vessel going from the right side. You can see the right ICA branches, but above this there is no circulation going above, and the entire vessel circulation is open. But you see on the other side, the other normal side, how everything is open. So what we did, I hope you are able to appreciate these 3 dots. This is the stent retriever put across the MCA here from MCA, M1 MCA into the ICA. So we do first pass. This is how the stent actually is inside the brain. You look at here. This is how actually the stent is placed. And then you see the stent retriever with the clot, how beautifully the clot comes out. And this is where we filter the clot and we just peel so that you can see the clot better in the bone with the gauze piece like this. You see how much clot we have got in the process. Then we achieved the ICA recanalization. Unfortunately, we are not able to get the MCA recanalization. So we again tried 2 passes of Solitaire and then got blocked. So you can see now, this is how the pre-procedure image looked like. Complete occlusion at M1 junction, M1 junction of the right MCA. But see how it opened up beautifully after this multiple stent retrieval thrombectomy. Entire vessel is opened up, including the M4 and largest MPR. So same patient with more time imaging showing continued recanalization. So another patient, flare diffusion mismatch, you can see large area of the brain showing diffusion abnormality. But flare, you don't see any abnormality, only you are seeing the insula and the vessel area. But all of these areas are not lighting up. So the flare DW match, mismatch. So we did the MR, we found out time effect as occlusion immediately as within the window period we did the angiogram. Right MCA was occluded. So it should be appearing something like this, but this branch is not there. So we did a Trevo-stent-retriever 2 passes and got this thrombus out of the patient. and you can see there is complete recanalisation of the another case, distal MCA occlusion with an infarct. So here you can see the M1 is preserved, but distal MCA is not seen. This is how the normal vessel should look like, the M1 and M2. But here you can see only one small branch is seen, the other, there are no branches seen out there, there is paucity of vessels here. So what we do here, we go selectively with small catheters to the distal MCA and give TPA there in each and every small branch, and we go and get the TPA there. Once we keep TPA, you see the recanalisation starts beautifully. You see all these branches positive and start reacting. That's how the TPA beautifully works in particular in selected cases. Another case, acute systemic stroke, we took, but we are very surprised to see that you can see the lateral angiogram. You see this branch is actually ECA. This is actually the internal maxillary artery, not the MCA or anything. These are the facial and the lingual arteries. Unfortunately, you don't see any vessel going in the chronic carotid of the brain. That means that ICA is occluded almost from the origin. You don't see the ICA at all and the MCA. So this apparent you should be able to appreciate in the angiogram. You see the other contralateral side beautifully, you will be able to appreciate the ICA and the MCA. ICA and the ECA branches beautifully in the common carotid. But in the abnormal side, we are not seeing any branch like this going on. Okay, so there is ICA occlusion. This is how it should have been, but it is not seen. So what we do, we go inside. It's a very fine microwire. Very gently we go inside, and we do something called as lacing. Lacing means we go top, get into the microcatheter and give small TPA dose from top to bottom. If you see, the moment we start giving TPA slowly, it started appearing like this. You know, the recanalisation started to appear. You can see the vessels are opening up. You can see now, ACA is, you are able to visualize the callosum marginal artery also beautifully here. So that means we are achieving some amount of recanalisation. But MCA we are not seeing. But we are seeing some kind of, so this gives us confidence that this clot is actually getting busted. So we now go to focus mainly on the MCA, because we have recanalized the ICA. Beautifully the ICA is recanalized. Then we go with the Trevo-stent-retriever like this. This is the M2, this is the M2. So I keep the stent-retriever across like that at the junction. We go here. Then we pull the clot out. You can see all these nice clots coming out with the stent-retriever. You can see this is the moving patient. So you will see the patient, the procedure is done without GA, only on the, you will see the move. So you will get some motion artifact, but you can see all the MCA branches start to appear. So now, once we actually finish everything, we did another fast run from the column. We realized the main reason why this patient developed all these ICA thrombosis and MCA thrombosis actually because of the tight stenosis at the right ICA origin. So usually there are two things: you can wait and watch and do a second intervention after a week or so, and the patient is stable. But in this patient, it is so tight that so significant stenosis, hemodynamically significant stenosis, that we thought we'll treat the patient immediately on table because he has very high risk of redeveloping the stroke. So what we did, we went inside it and we deployed something called the carotid stent inside. So we covered the carotid stenosis with the common carotid and the internal carotid stent. You can see beautifully the stenosis is covered, and there is good flow within the stent, and the distal flow is we're able to achieve this result. You can see how beautifully you can see the MCA and the ICA flow after this stage. So everything happens intra-procedurally. Once you do the procedure, you see all these things. So another few things that I wanted you to know. Another few treatments other than thrombectomy is just for your basic knowledge. You should know if you have a stroke with a stenosis like this, where because of the stenosis the flow is very bad. What you can do a small balloon angioplasty here. You see how we do a gentle balloon dilatation and achieve recanalization of the basilar artery and the PCA. Just a simple balloon dilatation of a basilar tight stenosis is the balloon angioplasty. Then we rarely do stent treatment. These stents are mainly reserved for chronic atherosclerotic disease, but in dire consequences we use sometimes stent. Balloon mounted self-expandable stents are there, but more and more neuro stents are more of a self-expandable type of stents. So common stent, the Neuroform, Enterprise, Geo, Solitaire, Wingspan. These are the common neurointraocular self-expanding stents that we use. Balloon mounted stents are not used mainly for the intraocular circulation. They're used mainly for like when you have a carotid or common carotid lesions, something like that. But those are also more of self-expanding stents. What you use for carotid, like PTG or other abort stents. So most commonly we use self-expanding stents, metallic stents there. So this is the stents actually you should know. Wingspan and they all work well. They are also used for stent filing, but you should just be aware of this kind of stents. So that you can see another case of Wingspan stent. We have a very tight MCA stenosis. So it was treated with the help of a Wingspan stent. This is how. So to conclude this presentation, endovascular stroke therapy continues to evolve and improve. The therapeutic advances have come a long way, and different directions like pharmacological improvement, mechanical improvement, different retrievals, perfusion systems, and aspiration systems. Different drugs have evolved and it will continue to evolve. So, strategies that has further improved our knowledge and our treatment, really helping many patients. So, with this thing, I'd like to conclude my presentation, and I would like to have some basic question and answers from all of you if you want to have. We have some time left in the presentation. Ask me some questions. Anybody interested? Any questions?